So welcome, everyone. Thank you for coming out tonight. My name is Felice Stonestrom, and I manage the community programs here at Packard Children's Hospital, Stanford. So as many of you know, our physicians host a lecture for us each year during the National Eating Disorders Week. And tonight's lecture is entitled, Let's Talk About It, Recovery from an Eating Disorder, a Personal Story. We have three speakers tonight. Dr. Neville Golden is the Marin and Mary Elizabeth Kendrick Professor in Pediatrics, Chief of Adolescent Medicine, and Director of the Adolescent Medicine Fellowship Program at Stanford University School of Medicine. Over the past 30 years, his clinical research has focused on the medical complications of eating disorders in children, adolescents, and young adults. He is the lead author of the 2015 Society for Adolescent Health and Medicine position paper on medical management of restrictive eating disorders in adolescents and young adults. Dr. Jennifer Durin is a clinical associate professor of psychiatry and behavioral sciences in the Division of Child and Adolescent Psychiatry. She completed general psychiatry residency and child and adolescent psychiatry fellowship training at Harvard Medical School's Massachusetts General Hospital and McLean Hospital. She specializes in treating eating disorders across the lifespan and is currently the attending psychiatrist on the Comprehensive Care Unit for Eating Disorders at Lucile Packard Children's Hospital, Stanford. Kristina Safran is the co-founder and executive director of Project HEAL, Help to Eat, Accept, and Live, a 501c3 nonprofit that raises money for people with eating disorders who cannot afford treatment, promotes healthy body image and self-esteem, and inspires people to believe that full recovery from an eating disorder is possible. To date, Project HEAL has raised over $450,000 and sent 21 applicants to treatment. They have opened over 40 chapters across the United States, Canada, Mexico, and Australia. Kristina graduated from Harvard College with a bachelor's degree in psychology in May of 2014. Kristina hopes to pursue her PhD in clinical psychology and go on to treat people with eating disorders. So please join me in welcoming our speakers.
Thank you and welcome everyone. My name is Neville Golden and I'm your first speaker. When confronted with a family with an eating disorder in our outpatient clinic or on the inpatient service, I look at the parents and I know they're thinking of two things. One is, will my child get better? And the second thing is, how long will it take? And hopefully this evening, between the three of us, we'll be able to address some of those questions. When I think of recovery, I think first of all for anorexia nervosa, we're talking of weight restoration, most importantly, metabolic recovery, reversal of the medical complications, but also resolution of some of the cognitions around weight and shape. For bulimia, we're thinking of interruption of the binge and purge cycles, and there again, also resolution of the distorted body image. We've known for a long time that we can promote weight gain on inpatient units, and we know that because they are controlled environments. This is a study from a long time ago, more than 20 years ago, on our inpatient unit when I was working in New York. And at that time, we had 2 behavioral contracts. And you can see here in the blue that when we increased the amount of weight gain expected, patients did that. But you can also see that it took 28 days in order to gain 10 pounds. So what happens if someone has to gain 30 pounds? We can't keep people on inpatient units anymore, not for that period of time. We have subsequently learned that the older refeeding practices really prolong hospitalization. And actually from our colleagues up in San Francisco, in a study of 35 patients, they showed that in 82% of cases, 83% of patients actually lose weight those first couple of days of hospitalization. And actually it takes about 8 days until weight gain is achieved. What they found is that higher calories is actually associated with reduced length of stay and also faster weight gain. What we showed over here at Stanford in a much larger sample of about 310 patients is that when we started patients on a higher calorie intake, that is greater than 1,400 kilocalories a day, compared to those started on a lower calorie intake, length of stay was markedly reduced without complications. Now, both 1,400 and even 2,000 calories are not a lot of calories for someone, for a young adolescent, but this is higher versus lower. The recommended rate of weight gain on inpatient units is really somewhere between 1 and 2 kilograms per week. What about outpatient weight restoration? Jim Locke is sitting at the back over there, and in a study conducted by him and also one of his colleagues, Dr. Couturier, and they studied 86 patients who are adolescents in family-based treatment, also a fairly confined, controlled environment, and they found that mean time to recovery for weight was approximately 11.3 months. That's about a year, and that's weight more than 85% of median body weight. They also found that the mean time to psychological recovery was longer than that, more or less 22.6 months, and we're going to hear more about that a little bit later. But I think what's really important is that most weight and psychological recovery occurred within that first year of treatment. Again, very, very important. But what about the real world? Not everyone is in a study that's fairly well controlled. So this is a study, fairly recent, 2011. Stanford was one of the sites. This is 11 adolescent medicine-based sites across the country, and looking at a large number of patients who were followed for up to a year. And you can see that depending on the site, somewhere between 42, 43, and 63% of patients actually achieved weight gain to greater than 90% of expected body weight 1 year later. Importantly, improved outcome was associated with shorter duration of illness and a lesser degree of malnutrition at presentation. The implications being the shorter duration of illness and the less malnourished you are, the better you're likely to do. Interestingly enough, one site didn't do any better than any other site, and Stanford was one of those sites. And that's because not everyone is getting family-based treatment, not everyone is getting consistent psychotherapy, not everyone is consistently monitored. So what about metabolic recovery? This is a study that we did in the late 90s, looking at 50 patients with anorexia nervosa and looking what happened to their metabolism during 6 weeks of hospitalization. And the dotted line over here represents normal resting energy expenditure. And this red line over here is basal, and the yellow is postprandial, that is after a standardized meal. And you can see that at presentation, resting energy expenditure was really low. People are hypometabolic, and actually it didn't really recover even over a period of 6 weeks. In contrast, the postprandial was still low, but it increased dramatically, and explaining over here that by about 4 weeks, caloric requirements are as high as 4,000 calories a day. And many of you in the audience who have had children with an eating disorder or who have had an eating disorder themselves may realize that it's really hard. You need to take in a lot of calories in order to continue to gain weight. What about some of the other medical complications, real quick? So patients admitted to our unit are often admitted because of low heart rate. That resolves pretty quickly, though. You can see here, usually by day 7 to 10, heart rate resolves on inpatient units. The orthostatic changes, the changes in blood pressure from lying to standing, depending on whether you use a cutoff of 35 or 20, it's somewhere between 9 and 18 to 20 days before those resolve. So that does take some time. What about resumption of Menses? This is a study looking at 100 patients. We prospectively followed them for up to 2 years. Every 3 months, we assess their body mass index, their skin folds, and also their hormones. And what we found is that after 1 year, 2/3 of them got their periods back, shown here. And after 2 years of those in treatment, 95% got their periods back. Now, this is important because resumption of menses is an important objective marker of biological health. We found that it took on average about 9.5 months for that to occur, and that occurred at a weight approximately 90% of expected body weight, which translates to about 95% of median BMI. And importantly, we found that there was a critical estrogen threshold above which it was most likely to occur. So we can use this to determine an individualized goal weight for any particular individual. Not everyone has to be 100% of median BMI. Some people need to be less, and some people need to be more as well. So depending on what their estrogen level is, we can predict whether or not they're at a healthy weight to get periods. Just 2 more complications. This is a study looking at brain atrophy, cortical atrophy. If you look over here on your left, this is the brain of an 11-year-old with anorexia nervosa. And if you look over here at the size of the ventricles, you can see that they are enlarged. And on your right, there's a normal 11-year-old, and you can see the difference between the two, and the brain actually shrinks in the acute phases of malnutrition. The question is, does that reverse, and how long does it take? Earlier studies had showed that after 1 month and 3 months, there was no reversal, but in a study we looked at, showed that at an average of 11 months, the ventricular enlargement shown here in the red, the ventricles are really large in the acute phase of malnutrition, but after 11 months, they reverted to normal, and they were no different from controls. So that takes about 11 months. Final medical complication I'm going to talk about is bone health. This is a bone density scan, and over here, whoops, sorry about that. Over here, you can see this is the bone density of a 14-year-old girl. This over here, this line in the middle is the normal, plus 2 standard deviations, and then minus 2 standard deviations. So at 14, her bone mass was normal. And she was a soccer player, and what should have happened is that her bone mass should have gone up with time. But instead, it went down. And it went down to the point that when she was 19 and went off to college, she actually fell on the ice in upstate New York and sustained a fracture of her humerus, which is one of the big bones. So the question is, does the reduced bone mass resolve? And what we know is that after 1 year of treatment, really 50% of individuals still have low bone mass for age. After 11 years, a study from Europe, you can see that bone mass was still reduced compared to controls, even in those who did really well in treatment. And in a small sample of after 21 years, you can see that in 19 subjects who had recovered fully 21 years before, bone mass was still low compared to expected for that age. So to put it all in perspective, electrolyte disturbances we did not talk about, but those we're pretty good at resolving within a day or 2. Metabolic abnormalities and vital sign instability reverse within a few weeks. Weight gain is more prolonged, taking months to maybe even a year or 2. Resumption of Menses and ventricular enlargement of the brain takes a little bit longer, probably around about a year, more or less. Eating habits, I'm not sure, maybe we'll hear more from Dr. Duran. Takes much longer though. And then reduced bone mass, we don't really know. I just want to end off with 2 slides to show you that for adolescents who develop an eating disorder, the outcome is much better than for adults. And this is just a conglomerate of a number of different studies. We hear the numbers that for adults, about a third do well, a third do intermediate, and a third do poorly. That's referring to someone who's had an eating disorder for many, many years. And in general, adolescents tend to do much better. And it really depends on how you define recovery, and Dr. Locke has written a beautiful article describing that. Are you just talking about weight? Are you talking about what level of weight? Are you talking about what's going on in your cognitions? But one study that I really do like is a study that was conducted a long time ago by Dr. Strober and his colleagues at UCLA. And why I like that is because they defined what recovery was beforehand, and they monitored patients every 6 months for up to 15 years. And what they showed is that in adolescents, full recovery was possible in almost 80%. But it was, in some cases, prolonged. So the message I want to leave you with is that recovery is possible. In adolescents, up to 80% recover. Much of the recovery can happen within the first year. Sometimes Dr. Strober showed it can take as long as 5 years or maybe even a little bit longer. But the earlier the intervention, the better the outcome. Thank you.
All right. Well, thank you, everyone, for coming, and thank you to Dr. Golden for getting us started off in a really lovely way. I want to echo his concluding statements about the fact that we should be hopeful about recovery, particularly in children and adolescents. We know that when people get good, high-quality treatment from people who are experts in the issue, that they do really, really well. So many of you may know that actually the DSM, which is kind of the Bible of psychiatric diagnoses, was updated in the past year. And so I just wanted to just very quickly go over the different illnesses that we're talking about when we do talk about eating disorders. And so I think very often we think mostly about anorexia nervosa, maybe bulimia nervosa. But as someone who works really extensively with inpatients and obviously in a hospital setting, I can tell you that we're talking about more than just typical anorexia and bulimia. That we're also talking about binge eating disorder, which has become an official diagnosis as of this printing of the DSM. An avoidant restrictive food intake disorder, which captures people who have had difficulty maintaining adequate body weight, but may not have all of the typical psychological difficulties that we might typically associate with anorexia or bulimia. And then we have the other specified feeding and eating disorders, which will encompass problems such as anorexia that doesn't meet all of the diagnostic criteria, bulimia in which someone has binging and purging cycles that don't come up to the full expectation that we would typically see. As Dr. Golden got us started off by talking about, the natural history of recovery from an eating disorder is not just about the medical recovery. The way that I think about it, it can really be broken down into 3 distinct stages. And that's not to say that they don't overlap, because I really think that they do. But there is a very thoughtful way that we think about treatment when we're approaching eating disorders. And we want to make sure that we're really triaging and addressing the most life-threatening issues first and foremost, and then working on the behavioral and the psychological changes that are going to need to happen in order for someone to get to a state where we can say that they're really recovered. So as Dr. Golden already talked about, when we're talking about medical recovery, we're talking about weight restoration, getting to a point where someone is able to maintain their weight within a healthy range, that they've been able to correct their underlying electrolyte abnormalities, and that they're really functioning normally across organ systems. And he's talked about those in great detail. When it comes to behavioral recovery, on the other hand, though, this is where we're really talking about normalizing eating behaviors and activity. Someone who is able to get to a point where they're exercising in a healthy and controlled way and not falling into compulsive exercising or activities that are becoming problematic. And then really being able to stop compensatory mechanisms such as purging or misuse of substances such as appetite suppressants or other medications that are really aimed at trying to control weight or shape. And then finally, when we're talking about psychological recovery, this is really focusing on those cognitions that Dr. Golden mentioned in his portion of the talk, We want to see people have the ability to resist falling back into unhealthy patterns of exercise, restrictive eating, and compensatory behaviors, despite the fact that they may be faced with really triggering situations. We want them to be able to enjoy healthy and normal social activities. So one of the things that I will often talk about with people in a more kind of casual treatment setting is that, ultimately, I think recovery does mean different things for different people. I've worked with a number of individuals who've been able to keep their weight stable and to have normal vital signs and good labs for many years, but they still think pretty incessantly about weight and shape. That the prospect of going to a birthday party and having a piece of birthday cake can instill fear in them, and they may actually even avoid those sorts of settings as a result. And I'm not saying that you need to love doing things like putting on a bathing suit and going to a pool party, but I do think that you've reached a pretty significant level of psychological health if you're able to say, you know what, I don't really love the way I look in this bathing suit, but it's fun to be at a pool party with my friends, and it's fun to go swimming, and so I'm going to do it because it feels good to be out and to be active. I also want people to be able to resist the urge to allow fluctuations in weight, shape, or body image to really control how they're feeling about themselves. When someone says that their whole mood or their anxiety about the day or their ability to function is dependent on what the number on the scale says or how they feel in their favorite pair of jeans, I think that's worrisome. And so I really want people to get to a point where they're able to withstand those ups and downs. In terms of the treatment approaches, we really know that family-based therapy, which was developed by Dr. Locke and colleagues, really has the most evidence to support its use, especially in adolescent anorexia nervosa, and that's the treatment modality that we focus on most extensively with our patient population. However, in adults or in individuals who are not struggling with anorexia nervosa, there are a number of other treatment modalities that also have evidence to support their use, and those include things like cognitive behavioral therapy, interpersonal psychotherapy, and adolescent-focused individual treatment. And in terms of treatment settings, there are a number of ways that we can really focus on looking after someone's recovery process. In my work, I spend a good amount of time on an inpatient medical unit that has very strong psychiatric support, and we're focusing on the medical recovery piece, but also starting to instill some of the principles and to educate people and get them ready and get them set up so that they can start really focusing on that behavioral and psychological recovery piece. Our preference is really to keep young people, especially children, with their families as much as we are able to, but occasionally we do make recommendations for residential or partial hospital treatment. And the vast majority of the treatment that we provide is really in an outpatient setting. And here's the point in my discussion with families where I'm often stopped and parents say, well, wait a second. If you're telling me that people do best when they get early treatment by people who are experts and specialize in the treatment of eating disorders, shouldn't we hit them with everything that we've got right away? And my response to that is always that more is not always better. That I think it's a lovely thought to hope that if we fix the underlying psychological problems, that will lead to medical recovery and behavioral change. It doesn't mean that in the early stages that we don't talk about the cognitions that are coming up, that we don't focus on helping people internalize better coping strategies, relaxation strategies, and all of those sorts of things, because we do. But we know that in order to really get to that long-lasting recovery, that we do need to focus on first things first. So we need to take care of the medical health piece first and foremost. Then we really do need to focus on changing behavior, whether or not someone feels like it's the right time or that their anxiety is under good control. And that's the piece that's always really hard. So we know that more is not always better, and we also know that the timing may sometimes seem counterintuitive. But as treatment providers, we're all working on the same page to make sure that we're prioritizing different things at different points in the recovery process. In terms of the treatment team, I feel very thankful to be in a setting where I work really closely with adolescent medicine providers who are experts in eating disorders. So I don't feel as much pressure about having to worry about those medical complications and worrying about monitoring vital signs and electrolytes and all of those sorts of things. It is really important to have someone on the team who is a psychotherapist who has expertise in treating eating disorders and who is familiar with all of the different evidence-based modalities and can help a family decide what the best approach is going to be for them, making sure that they have all of the information at hand. I say plus or minus psychiatrist because even though I am a child and adolescent psychiatrist, I know that far and away the best treatment for recovering from an eating disorder is to regulate and normalize eating patterns. There's not a magic bullet. It's not going to be a medication. It's not going to be, the perfect psychotherapy match, but it really is regulating those eating patterns, and that's why it's so important. Oftentimes, the dietitian will be part of the treatment team. In family-based treatment, we say that, parents actually are really experts at knowing their children, and they also know how to feed a child. And they know how to feed themselves. Most of us do. We don't need to necessarily consult with a dietitian. However, if a family is feeling like they would like some advice and consultation, we are very much in support of having a dietitian be part of the team, so that parents can feel comfortable and feel empowered and know that what they're doing is the right thing. And then just a note on psychiatric medications, because I feel like in my line of work, I get asked about this very often. We know that food is really the best medicine, especially for mood and anxiety symptoms that appear to be related to malnutrition. Now, if someone has a co-occurring condition like depression, anxiety, attention deficit hyperactivity disorder that really predates the development of the eating disorder, that's a different situation and one in which we may consider adding a medication. However, I'm really quick to point out to patients and families that these medications actually don't work as well as they might unless someone's nutrition is really up to speed and that they're getting in adequate nutrition. We also know that the risk of side effects may be higher in people who are malnourished, and the medicines themselves may actually not even be tolerated that well. I have had the experience of working with individuals who had been on psychotropic medications for quite some time, and they seemed to be tolerating them fairly well, and then actually as their symptoms improved from an eating perspective, they actually noticed a vast improvement in the antidepressant or anti-anxiety effect of the medication. And it wasn't that we changed the dose of medicine. What had changed was that their nutritional status had really improved. The other thing to really point out is that the FDA has not approved any medications for use in children and adolescents with eating disorders. It has approved 2 medications for use in adults, fluoxetine or Prozac at 60 milligrams for bulimia nervosa. And the one that has just come out, you've probably seen in the news, is lisdexamfetamine, which is marketed as Vyvanse, which has been approved for the treatment of binge eating disorder. And there's a lot of controversy surrounding that. I'm happy to address questions about medications in the question and answer portion. But I did want to just kind of briefly touch on a number of these very common questions that come up in my day-to-day practice. But I think we all agree that we're here to hear Kristina and to hear about her story. And so without further ado, here she is.
Well, thank you, Dr. Dren. You set me up beautifully for my talk, so that's good news. Hi, everyone. I'm Kristina. It's fun. I know some of you. I feel like I only moved here in July, and it's a small and nice community, so it's really nice to recognize a couple familiar faces. Thank you for coming out. Can you hear me okay before I? Okay, great. So I am the co-founder and currently the executive director of Project Heal, which is a nonprofit, as Felice said, that raises funds for people with eating disorders who can't afford treatment, promotes healthy body image and self-esteem, and encourages sufferers to believe that full recovery is possible. I also have myself recovered from anorexia nervosa, and so I think what I'm going to do today is tell you guys a little summary of my own story, and then really get into some tangible things that were helpful for me in the recovery process. I think going through the eating disorder myself, frankly, the most helpful thing was when people came and talked to us, and I always wanted some tangible things that I could hold on to, even though I know the process is different for everyone. So hopefully I can provide you with some of that. So I was diagnosed when I was 10 with anorexia. People have always asked, why at 10? Frankly, I think, unfortunately, I am someone who's very genetically predisposed to developing anorexia. We know that there are strong genetic predispositions towards this disease. Ton of anxiety, depression, perfectionism, neuroticism, all of that runs in my family. And frankly, I think it was something as simple as we had a babysitter who was dieting in the house, and I wanted to copy her because I looked up to her, and unfortunately my physiology reacts quite badly with diets. So my parents caught that bout early, brought me to a team, and I basically saw psychiatrists, nutritionists, therapists, weekly providers for that year. Went well, thankfully. Got better, went to middle school, did great. Remember joking with my friends, like, I couldn't have an eating disorder anymore if I tried. Unfortunately, that was false. When I was 13, it was last year of junior high school, I slowly began to relapse. And I think looking back, it was two main things that caused that relapse. One, I was beginning to enter puberty for the first time. I had delayed the onset of it with my eating disorder at 10, and I was kind of used to being the little one amongst my friends who hadn't gone through puberty, and that began to change, and I flipped out. And then two, my parents at the time were fighting a lot, and I was the kind of kid who internalized a lot of that stuff, didn't want to go to them and talk about it, and so instead I sort of took it out of myself. And unfortunately, the combination of those two things led me slowly but surely into restricting my food intake, and it spiraled pretty quickly. So long story short, after 6 months, my parents, probably in more denial than I was, frankly, at that point, finally after 6 months was like, okay, something's going on, and took me to a doctor, and that started my freshman year of high school, which was marked by not being in high school at all. Frankly, it was 4 different hospitalizations for a total of 7 months. And that's the point where the eating disorder really, really took a hold. I mean, when doctors, unfortunately, I did have doctors who told me, like, you're going to be a chronic case, you're going to be, sick forever. I thought that was the best accomplishment I had gotten. I thought that was great. I thought that was cool. I saw the older women in the treatment program who had struggled for 30 years, and I wanted to be that. I would say around my third or fourth hospitalization. It's not that I wanted recovery by any stretch of the imagination, but I got to a point where I was like, okay, maybe I don't want to be doing this for the rest of my life. Like, I'll recover at some point, but not today. Going forward, I got out of my last hospitalization, my fourth hospitalization. And actually at this point, I had kind of resolved myself to the idea of, they say recovery is ambivalent at best, and that's what it was for me. But I was going to give this a shot. And I remember leaving my last hospitalization 2 pounds above my goal weight. I should add 2 pounds above my minimum hospital goal weight. And in my mind, I said, okay, I can do my goal weight. I can do that. I can't do 2 pounds above it. So I'm just going to lose these 2 pounds. And as many of you know, probably that did not work. So that was actually my third hospitalization, ended up in my fourth hospitalization. The scariest hospitalization for me, and that I went in psychologically being like, I don't look like I need to be here. I'm not the sickest here. And there was, shame associated with that. But it was great for me to be there because I really had to focus on, a lot of the issues, and giving me that additional 8 weeks in treatment was really important. So then got to a place where I was like, okay, maybe can try this out. Was doing well for a couple of months, began to slip a little bit, and my parents were like, okay, this is it. You have a choice. You're going to residential treatment, or we're going to do a modified version of family-based treatment. It was not the manualized method. I won't use those terms around here, but something similar to that. And frankly, at the time, I wanted nothing more than to go to residential treatment. I mean, treatment was great. I love treatment. It was a safe place. I had a community of people who understood me. I didn't have to deal with any of the stressors of life. The thought of going back to high school, starting my sophomore year, starting essentially from scratch, was absolutely terrifying. But I still credit this as one of the healthiest decisions I've ever made while I was in kind of a sick place. I said, I know treatment is easy for me, and as much as I, go in, it only gets harder to come out and re-enter sort of the normal world. And so this is not going to be easy, but I might as well. It'll be less bad doing it now. And so gave that a try. We did this sort of modified family-based treatment. My best friend actually supervised me at lunch. To this day, she's one of my best friends, and I thank her for it every day and think it was one of the most mature things a 15-year-old could do. And I think, honestly, 6 months in, it did get to the point where I was still ambivalent about recovery. It was still hard. I think when my parents gave me back control of the eating intake, I wasn't, jumping for joy, and there was definitely a trigger to go back to the eating disorder. But at that point, I had built up so many things. It was January of my sophomore year. I was in a school play. I had started developing some new friendships. I was like, I might as well keep going. I sort of use the analogy that maybe of some of you have heard. You can sort of put the eating disorder on a box. It'll in a box in the closet. It'll always be there if you want to go back to it. But try this for now. And one of the more helpful things was that in one of my first treatment centers, I met Leanna, who's my co-founder of Project Heal. And the two of us got back together at that point, now a year later, and really developed this really healthy recovery-oriented friendship and encouraged one another in recovery. Through, as we got better, and I'll touch on friendships post-treatment because I have various views on them, but Leanna was great, and we did not enable one another. We went out for dinner and we went out for dessert every single time, and we were really pushed one another on recovery, and so that was really helpful. And I would say about 6 months into our friendship, as we started doing a little bit better and our conversation shifted from what was wrong with all the problems we were having to the problems we were seeing in the treatment world, it really centered around these three things. One, that we had seen so many people not being able to afford treatment, getting kicked out of treatment before they were ready, and frankly, people who were far more motivated to recover than we were at the time. Two, we got back to high school, we had all these healthy coping skills and affirmations, and this is a healthy way to eat, and this is what you should do. And we realized that it wasn't just people in treatment, but, our quote-unquote normal friends from high school struggled with a lot of these issues as well. And then three, and this is one of the reasons I'm so glad we're having this talk today, is that when Leanna and I were in treatment, there was nobody to look to as a role model that recovery was possible. Nobody at all who had recovered, and beyond that, who was living a pretty nice life and made recovery look like something worth striving towards. Recovery is hard. It's the most challenging thing I've ever done. And so I think role models to show you not only that it's possible, but that it's worth all that hard work is so important. So we wanted to serve as those role models, and out of this sprang the idea of Project Heal, which we started at 15 naively, and it's grown a lot over the past 7 years, and I can get into that. I'll get into that a little bit later because I do want to go into my kind of recovery speaking talking points for you guys. So hopefully this is helpful. It's 10 things that were really helpful to me in recovery. And actually, they follow Dr. Duren's talk really, really nicely, because I would say the first couple are really in that early stage recovery and focus more on the behavioral aspects of the disorder. And then the last couple focus more on that psychological recovery. And just actually to touch on that point a little bit more, I would say that essentially since I left my final hospitalization at the end of my freshman year of high school, I've been, weight-wise and behaviorally, besides like a tiny little slip, pretty much better. Obviously, it's now been many, many years, but pretty much better. I would have told you a year after that, and then behaviorally I was doing 100% because I was doing this family treatment approach. I would have told you a year after that I had reached a full recovery because it felt like night and day, so different and like really, really good. So I was almost there. In hindsight, I would say it was 3 full years past the point that I was fully weight-wise and behaviorally recovered that I was like, oh, this is full recovery. This is it. So it just takes a long time. And that's not to say, listen, a year later, it was so much better. It was really, really great. But keep working and challenging those cognitions because it gets even better. So with that, one thing that was really helpful to me is that I touched on this, but I kept waiting for a time where I was like, waking up and saying, I want to recover, I want to do this. And really that never came. It got to the point only where I was like, maybe I don't want to have anorexia for my entire life, but there was never like a click that was like, I really want recovery. I sort of had to make this conscious choice that I'm going to do it. And then, just go for it. And so related to that point, one of the things, kind of the mantra of my recovery was Autopilot. Fake it till you make it and Autopilot. I followed a meal plan, both with family-based treatment, and then when I transitioned on my own, I had a meal plan with my nutritionist, and frankly, for a couple of months, it was really important for me to follow that so that there were no questions, because I knew how manipulative my eating disorder was, and if I gave myself any room to question or think or let the eating disorder in, I knew what would happen. So I just had to say, this is what I'm doing. I would give myself, eat the meal, eat the snack, whatever it was, give myself a couple of minutes to freak out, and then just really had to go on autopilot. It was sort of, my third point is that you can have bad mental days, but I really couldn't have bad food days. And I think that came from earlier in my eating disorder. I had heard a lot of discussion around don't beat yourself up if you have a bad day, which I think is, very true. And there's a lot of validity to that statement. That said, honestly, my eating disorder interpreted that as I restricted. It's okay, Kristina. Don't worry about that. It was just a bad day. And you have too many of those, and that is just a spiral into a relapse. So I really had to make this pact with myself that there aren't bad food days. That just doesn't exist. And I think that is a little bit more specific towards anorexia, but I think that was really important for me. This is the fourth point. I kind of touched on this a little bit in my story too, but it just takes so long mentally. A couple of years, but it takes a long time mentally to get there, and there wasn't instant gratification. And as somebody who is a huge, needs a lot of instant gratification and really likes instant gratification as a very type A person, it was so frustrating to me that I was like, okay, I'm going to recover. I'm doing all this work. I'm eating. I'm at a normal weight. Why won't these thoughts catch up with me? And it just takes a while. And it's like classic exposure therapy, although it takes a lot longer. You eat, like a normal person and live in this normal body for a long enough time. It doesn't feel so scary anymore. It feels, more normal, and it becomes less of a big thing every day. My fifth point, and this is one I'd like to mention because when I talk about Project Heal, it's obviously my friendship from treatment was amazing and really impactful in my own eating disorder recovery. But I think it's important to note that I kind of think that's the exception rather than the rule. And I think especially in early treatment, I would be wary of treatment friendships. I think, unfortunately, it's not a conscious thing, but there is a lot of, competitiveness and just insecurity in this disease. And, when you're in that fragile place right after treatment, it can sometimes not be the best thing to be surrounded by other people who are still at a fragile stage in their recovery. What I didn't say about my meeting with Leanna is that the first time we met, we had this hospital reunion. 12 people from treatment went out to dinner, and it was the most horrendous dinner I'd ever had. I was still at the place where I was like, it made me uncomfortable to eat more than anybody else was eating, and people were eating very little. It was just not good. But 3 of us, after dinner, we did have a healthy dinner, and then we went out to Cold Stone after. And we invited everyone, and it was 3 of us who went to Cold Stone. And then the next dinner was the 3 of us. So, but I would say like the 13 is a sample size that you should look at, and I would just be wary of that. And beyond that too, I think that redeveloping, I hate the word normal, but like the normal healthy friendships, people without eating disorders, is also really, really important. And that was something that when I got back to high school, I didn't feel like I could relate to anybody in high school. I was like, I've been through all this, and I'm just like deeper and more mature, and we were talking about boys and homework, and this stuff is stupid. You don't understand me. And the people from treatment like really could relate to me and understand me. But at the end of the day, like, I was a sophomore in high school, and these were the people, I needed to have friends in high school. And there's also something nice about having that perspective of like, on Fridays after school, my friends all went out for pizza, and that was just what they did, and it was super normal. And just being with them and having kind of that healthy perspective was really, really helpful for me. My next point, get your head into other places and find something that's, meaningful to you. I think that's kind of goes to the power of distraction. It's kind of twofold. So one, to the power of distraction. I'm a big fan of CBT and, challenging these tricky cognitions that the eating disorder gives you. But sometimes you can challenge thoughts all you want and you still feel pretty shitty. And so that's a time when like distraction comes in and coping skills. And I always struggled with these kind of find your coping skills activities in treatment. They would have us write out these lists of like copious amounts of coping skills. And I actually really think that coping skills are one of the most important things, not just in an eating disorder, but like in life in general. When things get bad, like you need to have a couple of things that you can turn to. And for most people, I'm pretty sure it's not a list of 30 things. It's like a precious list of 1 or 2 things that like really can get you out of a very dark place. And so I think developing those was really important to me. And then beyond that, finding something that's bigger than you, I think is really important. I mean, one of the things, this kind of skips ahead a lot later to like, really longer term recovery. But I think when I like define recovery, it's really just having a life so full that food and weight and calories just like appearance take a back seat, because there are so many other important things in the world to focus on that are filling your life. There are really just so many things. And so Project Heal became that for me, but finding something that is bigger than yourself. I think a lot of people end up finding it in service related activities, but it can be something for everyone, is really great. Here's a really tangible one that was so helpful for me. I got rid of my scale, and that was like life-changing in my recovery process. I had always had a really like bad relationship with the scale and was really numbers obsessed, as I mentioned that anecdote about getting out of treatment and being 2 pounds over my goal weight. And later in treatment, I developed it wasn't technically an unhealthy relationship with my scale, as I was being seen as an outpatient, and my appointments went from like twice a week to once a month, once every other month. I chatted with my nutritionist and doctor and said, I want to have a little bit of time now. I'm seeing you guys once every 2 months. What if I weigh myself every other week at home? And they were like, that's fine. That's like a normal relationship with a scale. And maybe it was, and I only did it once every 2 weeks, but there was some power that it held over me. I was at a healthy weight. I had been at a healthy weight for at least a year at that point, but there was just something like stepping onto that scale. It was just an icky feeling. And I remember one of those set days I was on vacation, and so I didn't weigh myself, and it was so freeing. And then the next 2 weeks came, and I was like, what if I don't do this for a little while? And it was so freeing. And so I went 3 years without weighing myself, and it was amazing. It really, I think that really brought me into like full, and I was already at the place where I had been at a healthy place. This is my 3 years into being at a healthy weight, eating normally. That's when I got rid of my scale, and I really do think that brought me into full recovery. I was giving this recovery talk about a year and a half ago, 2 years ago maybe, and I said this, and somebody challenged me, and they were like, well, you're going on about how great it is that you haven't weighed yourself in like 4 years, 3 years. Do you think that's a bad thing? And I had really never thought about it. So I was like, oh, maybe. And so proud to report that now at doctor's appointments, I will, if they say get on the scale, I'll get on the scale. And, the first time I was like, oh, will this be a trigger? And thankfully it's not, because I've gone, so long. But I think I don't have a scale in my house. I will never have a scale in my house. My annual physical is more than enough. Okay, my next one. So my next one is redefining my image of perfection. This sort of gets to the point I was talking about finding something bigger. But it's funny, my co-founder and I complement one another beautifully, because she's the most amazing, like so inspirational, so caring, so comforting. If you've ever seen the Project Heal Facebook page, and I really encourage you guys to go to it, it's like the most inspirational page you'll ever find, with quotes and pictures and everything. She does all of that. I am like the least creative person. I'm like not like that. I'm a lot more like type A than her, kind of like hard, scientific, logical. And the type A perfectionism was something that, I always had to struggle with. And so I think in my recovery, it was really important to redefine like what that meant to me, redefining my image of perfection. I said it. And it was really helpful to have an actual working model of who I wanted to be. First, physically, I needed to change my image of what I thought as beautiful from, a more frail, anorexic type, figure to, a healthy, strong, someone with more curves and muscles, and, just physically reshaping that was really, really good. Much more importantly, though, who I wanted to be, my perfect person, the person I aspired to be, was so much more than that. Was just like an interesting person, cared about, the world and having meaningful conversations and developing meaningful relationships and, arguing with my parents about, things and being a teenager. And I don't know, it was so many more things that I couldn't do with my eating disorder. As part of that, it was someone who could go out with my friends for ice cream and, that's totally fine. That when I thought of, okay, who do I really look up to and what kind of person do I want to be? All of that was in the picture. And once I had that mental picture, it was a lot easier to work towards that recovery. One I love is, again, I said I'm not cliched. I don't really like cliches. But the one cliche, if you can call it that I fully believe in and support is this idea that confidence is beauty. Because I think that is just so true. I mean, when I look at people that I really think are so beautiful, when I really push myself on it, what is it about them? It has less to do with what they physically look like and a lot more to do with how they carry themselves and if they're confident in themselves. And so I think that's a great place to start. Like that is what to aim towards if you're looking to get more beautiful, work on confidence. And it really is kind of, it sounds like work on confidence, but it's like a fake it till you make it type thing. It really is. When I stepped out of my eating disorder, God, I could have never done this. I was like a shell of myself. I was someone who was, nervous to talk to anybody for 5 minutes, but you work on it and you push yourself. And my last point recovery is amazing and wonderful and the most worth it thing in the entire world. I mean, I live such a full life, food and weight and calories. God, there's just is not time to think about those things because my life is filled with so many other things, and it's fantastic. I think something that's important, though, especially in those early days of recovery, I see my recovery when I got to this full recovery point 3 years later. I hit this 6-month period. It was amazing, where I was just life is the most amazing thing in the entire world, and I'm riding on rainbows, and this is great, and everything's wonderful. And that's not realistic, right? Life is still bad things happen, and triggers happen, and just bad life events. Life happens, and you still have to be okay with that, right? And so I guess I'd worked so hard towards recovery that I had always had this image in my head of if I'm going to do all this work, it really just better be like that all the time. It better be the most perfect thing in the entire world. And just to know that it's not, it's life, and you deal with that and you move on. The difference is now I have a bad day, and it's a bad day, and then the next day is a good day. So I think that's important to share. That is the tips towards recovery. And I guess just to end it off, to tell you a little bit more about Project Heal. So we've been in existence for 7 years now. Frankly, I think one of the reasons we've grown so much, and right now we've sent 21 applicants to treatment. We have 40 chapters across the country, and we have over 10,000 followers on Facebook. That's the coolest to me, is that we didn't even work hard to get that much support, the chapters and the Facebook page. I really think it speaks to this idea that there was no voice that recovery was really possible, and it was such a voice that people needed. And so many people go to that site now, and it's this positive source of inspiration. And to see so many people sharing their stories of recovery, sharing that recovery is possible, has just been really awesome and inspiring. So I hope you guys check it out. Yeah, that's all.